Godmorgen alle sammen. Velkommen til OH Talks i dag. Foredragsholderen skulle lige kysse alle. Anthony had to kiss all the participants. Women, all the women, of course. Yes, this will be in English this morning. Welcome to the OH Talks. Remember, you can go on Twitter, ask questions. Today all the equipment is functioning, I've heard, so we are on streaming. So remember not to ask questions without a mic. So welcome this morning, and it's a very interesting morning for not only the hospital but for the whole region, for Denmark, because the new laws about cooperation with all the municipalities and the primary care doctors and the patients is that we have to work much more with telemedicine and virtual consultations and other methods that we could use at distance to be sure to help people from the hospital in their own environments, so they still feel that they have hospitals very close at them. So we are very happy to introduce Anthony Smith today. Anthony Smith is here because of our own professor from Children's and Youth Hospital and from our Center of Innovative Medical Technology, Jane Clemmensen. Jane has made a cooperation with Anthony and Australia for a couple of years, and we are trying to export our own experiments and introduce what we learned from Australia to Denmark. So it's a great pleasure to welcome Anthony Smith. Anthony Smith is also an adjunct professor at SEMT and a professor at the University of Queensland, as you can see here. I have one more slide, I think, because this is what we will hear a little about. I won't tell you what is standing on this slide, but it's something about how to use telemedicine in remote areas. But remote areas could today be on the other side of the street over here. So what we will learn now is something that we had to use in our daily business in the future, and the future is tomorrow. Welcome to Anthony.
Thank you. So good morning everyone, and thank you for the invitation. It's so nice to see all these familiar faces in the audience, and thank you for the kind invitation and the introduction to Peder. I've been invited to talk for 30 minutes about 20 years of work. That's my first challenge. What I'm going to do is apologise in advance. I'm going to give you quick snapshots of all the work that we've been doing over that period of time in the area of telehealth. As just mentioned before, I'm very fortunate to be here as an adjunct professor. And that's thanks to our partnership with Jane, but I'd also just like to acknowledge the university here and SIMT for the funding that provides support for me to actually come across. 37 hours was my travel time. Slight jet lag. I got up at 1:30 this morning, did some more work, connected up by video back to my office, and then I was able to talk to some staff and do my staff appraisals at the same time before coming here. So I feel like I've done my day's work. But anyway, I just want to acknowledge to Jane and also the University of Queensland and also my team in Queensland who are really behind a lot of the work that I'll talk about today. So I'm from Australia. Australia's a big place a long way away. How do we compare to people in terms of size and geography? So just putting Europe on the map, Denmark. Don't look too hard, but you will see Denmark in there. Beautiful Denmark is just up on the top, quite small. But one of the messages mentioned just before was about telemedicine not just being about distance, and I think that's a very, very important point. Telemedicine, historically, we all focus on long distances. We think about space travel, we think about people who can't access services any other way. So telemedicine has certainly changed. So 18 years ago, I used to get up and talk about how far away people travel in Australia, and it's a long way. But now we support people only 1 or 2 kilometres away from the hospital for all very good reasons. So Australia, we have a population of about 24 million people. The challenge for us is about 1/3 of the population live outside of the main city locations. And funny enough, our doctors and nurses and allied health staff like working in city locations and not in the rural and remote areas. So that means that we've got a bit of a challenge on how to provide good services to people irrespective of where they happen to live. Travel costs in Australia are very expensive. Our government supports and provides a subsidy for people who have to travel for a doctor's appointment, and that subsidy is in the tens of millions of dollars and going up every year. And one of the reasons for wanting to do telehealth right at the very basic point is the fact telehealth is about providing equity. If somebody lives in a remote location, why should they miss out on being able to get access to good quality services? So I see telemedicine as a way of trying to even up the playing field. These challenges on the screen are not uncommon. They're not Australian challenges, they're our challenges. So if you think about it from the perspective of our ageing population, I could run this list. Cost of providing hospital care and outpatient care, equity, as I mentioned, technology is constantly changing, the need for new models of care, and also providing evidence for changes in practice. So all of these factors are not uncommon for any of us. These are all the reasons behind what we do in the telehealth world. In Australia, you might have heard of the Royal Flying Doctor Service. They provide an excellent service around the country, providing not only emergency medical support, but also public health services. Now, we're working with the Royal Flying Doctor Service to see how we can do more telehealth work in conjunction with the work that they do. So they fly in, fly out to very small communities. It's done by aircraft, and these services are very, very important for the remote communities. This is a road I travel along between two towns. I travel for about 2.5 hours without passing any vehicles at all. So that gives you an idea of remoteness. I do pass kangaroos, I do pass emus, tortoises, snakes, and wild boars, but no cars. So there's no internet reception, usually satellite only if you have that for emergency contact. So put yourself in the shoes of a patient who's travelling for an appointment. Also put your shoes in the foot of the person who's driving the screaming kids who need to go for an outpatient appointment, and they're off to Brisbane. And how far is Brisbane? That's in kilometres. So telehealth, just to put it into really, really simple form, many of you are doing telehealth anyway, but telehealth is very simply about the delivery of a health service across a distance from one point to another. That distance could be metres, or it could be many, many hundreds of kilometres or thousands of kilometres. You can use a range of different communication techniques, and we often talk about real-time telemedicine or store and forward telemedicine. So a common example of real-time is simply picking up the phone and getting advice on the phone or doing a video link. And store and forward is about perhaps sending an email, a digital photograph to a dermatologist and getting advice. So I like to keep it simple. There's no point trying to make it complicated. So whilst the focus has always been on remote communities, we're now looking at supporting people in all areas. So why do telehealth? The obvious thing is we might do telehealth if there's no other option. So if you're an astronaut, historically a lot of the telehealth work came from NASA to support people who were not on this planet, and therefore how are we going to do telemonitoring and provide some medical advice if needed. The other thing, and I really like to put this point forward to everybody, is that telehealth might actually be better than what we currently do in the conventional system. Some people get very uncomfortable with this point, but I think it's very important for people to step back and think, we deliver services to people every single day. Is this really the best way of providing the service? And sometimes telehealth could be better than conventional services. Anyone like Mythbusters? I just want to put up some myths, because some people kind of will say, this guy is talking about telehealth, this guy thinks telehealth is going to solve all the problems of the world. This guy doesn't. I don't think that at all. In fact, some of the common myths is that some people worry that we're using telehealth to replace all face-to-face appointments, and that's not true. But you only have to look around your own hospital and look at every single patient and think to yourself, does that patient really have to be there? So question and think about that next time. People also say that telehealth is not good for older people or those that can't understand the technology. That's not true either. I think with the appropriate training, it's no problem at all. In fact, you'd be surprised how older people really manage their tablet and devices, to link up to their grandchildren, other siblings. They're quite amazing. So I don't see that as a drawback at all. In fact, I've only ever had one problem, and I mentioned it to a group yesterday, in terms of doing a connection to an older person for a consult in the home. And when she was given instructions to go and get her tablet, she actually brought her tablet instead of a tablet. So that's the only one I've ever seen, but it was a very simple situation to say, we actually meant that little TV that looks like a tablet. People think it's going to solve every problem of the health service, and it simply isn't. It's going to contribute to some of the answers. Does telemedicine save money all the time? It can save money, but it can also cost money, so we have to be real. And when I talk to ministers in Australia about telemedicine, and we think about funding models, and we think about policy changes, they certainly like it when the message is, we're going to save money. But I think we need to change that message, and the message needs to be, not only saving money, we might use money in a much better way and provide more service to more people in a much more effective way. And I think that's where we need to go. The other trick is that telemedicine is easy to implement. I would like to say it is, but it's not, because it's not about the technology. It's about working with people and helping people change the way they work. Now, outside of the telehealth world, change management is a long-term process. It needs time, and it needs effort, and it needs to be focused. So I'm the director of a centre called the Centre for Online Health in Brisbane, Queensland in Australia. We've been running for almost 20 years now. I have about 25 staff who run a range of different projects. We have 21 projects, and I don't have time to tell you all about them, but our focus is better healthcare and stronger communities through the use of telehealth. And we look at applying telehealth to address some of the challenges in the health system, and we're quite unique in the sense that we have four main pillars of work. So because we're a university centre, we can't escape the fact that we're primarily a research centre, but we actually get our hands dirty and provide services. We also do consultancy, and we also do teaching to students. So that just shows you a couple of examples. We became a Centre of Research Excellence in Australia with a 5-year funding grant. Our income, we've earned about $3 million in grants. We publish about 20 to 25 papers per year amongst all of our different projects, and we've got about 15 students, PhD and master's students with us at the moment. So we're reasonable in size. We're quite broad in terms of coverage. We do a lot of projects from very small children up to much older adults, so across the age spectrum. About 17 or 18 years ago, I set up a service in Queensland called the Telepediatric Service. We ran that for 15 years through a service level agreement. In that time, we conducted over 23,000 consultations for lots of different specialties. My approach was to attack every single clinical discipline and make sure that they're all doing some telemedicine work. I could tell you a lot of stories about those that put up resistance, but we eventually won. So there are groups out there that will say, I'm not going to do this, get nicked. And I would basically say, look, that's fine in your own time. And a week later, I'll keep going back, and I'll keep going back, and I'll keep going back until they change their mind and start doing it. And that's worked with some of our groups, and I won't name people, but there are some groups that take a little bit longer and need a little bit more support in order to be able to see how they can do this work. So lots of different specialties. In this process also, we got to do some fun things because we're working in a kids' hospital. You've got to make it fun for the kids. So we built robots, and these aren't robots that are going to walk after you and grab you by the shoulder and lift you up and put you into the surgery room. But these are robots that we can use as video conferencing devices. And again, it's very, very simple. It was a video conference device with wireless networking. We operated all of these robots remotely, and we could do virtual ward rounds. So the doctor's face in Brisbane was on the face of the robot that was a long way away in a children's ward. The kids and the families loved it. We were able to support nurses and also junior doctors in these areas and provide virtual ward rounds twice a day. That lasted for 12 months before they eventually recruited a real paediatrician, and I still think the robot paediatrician was better. We did burns care. This was one of the groups that were a little bit reluctant to take on telemedicine, but with some gentle kind of coaching, eventually they picked it up, and now they do a lot of telemedicine work. In fact, their whole model of care has changed. So the model of care used to be bring the children in to the specialist centre and we see them. I used to work in the burn centre, and I remember morning for outpatient appointments, about 30 families would come in. Half those families didn't live in Brisbane. About half of them travelled for 6 or 7 hours. Now, out of those families, I saw them go into outpatients and I saw them leave. And some of those families are there for 3 minutes. 3 minutes. So much better way of doing this is video linking for their outpatient appointment. So in this particular study, we worked out over just a 14-year period about 2,000 of these appointments, and it was a bit of fun to work out the distance between where they lived and also the distance to the Brisbane hospital. We worked it all out. It's about 2.8 million kilometres. Now, when I go to America and tell them that 2.8 million kilometres, they just go, wow. But to put it into real context, it's 4 return journeys from Earth to the moon. So that's just our burn service. That's just 2,000 consultations. The 2 big programs I've been running over the last 18 years, we've done 65,000 telehealth consultations for 72, 73 different clinical specialties. Very, very broad. We do work in mental health, in psychiatry. We also have done work to look at the economics of providing telepsychiatry services versus outreach services. This is really interesting because although this is a very simple economic analysis, it's a way of what does it cost to provide telemedicine, what does it cost to send a team out to the remote site, and what does it cost to bring the families into us to be seen in person. And we're able to work out those costs per consultation over the activity line. And this is important because it helps us make decisions about whether or not telemedicine is the best option. In this example, we conducted just over 600 consultations. And you can see there that the telemedicine option is clearly the cheapest. But to be fair, had our activity been a lot lower, what happens if we were doing 100 consultations? Then the choice may not have been telemedicine because of the upfront cost of setting telemedicine up. I would have gone and said, look, I think it's cheaper to send your visiting psychiatrist out to the remote site. So this is just important to say that, again, don't assume telemedicine is going to be cheaper. It does depend on a number of factors. But this is one simple way of doing it. It's called a cost minimisation analysis. Anyone seen this cartoon before? In 1962, I learnt that the Jetsons came out and they predicted what it would be like in 2062. Now, there was this funny dream that eventually we could look at someone on the screen and open their mouth and say, ah, and look inside the mouth, inside the nose and the ears, and we're all doing that now in tele-ENT. So using a simple videotoscope connected to a video conference system, you can assess the patients remotely. This has huge value for people who are coming down for Brisbane appointments, any city appointments. Again, people are coming down for pre-admission, they're being checked out, and I would see families come in with their little suitcases and their toothbrushes, only to be told you need an operation and we'll put you on the waiting list. So off they go again back home and they come back for the operation. So we're not doing any surgery at a distance, although we're looking for volunteers. But what we are doing is pre-admission screening where we can look at these kids and determine whether or not they need to be coming down before they actually arrive. Now with these cameras, in Australia we have a major problem with our Indigenous population, particularly our young kids and ear disease. We got the idea to actually connect these up to our computers and collect images and make them available for an ear, nose and throat surgeon. So I bought a Mercedes Sprinter van and I turned it into a mobile hospital. And a mobile hospital meant that we had all the screening equipment inside the van. I employed a health worker. In the bottom left-hand corner is our hero in our Indigenous community. His name is Pickle, and he provides the routine screening. He drives this van around to all the schools. He does assessments on the children. He collects images of the ear, nose and throat and the histories. And that information goes into a computer, and that information is available to our specialists and also to the local medical doctors in this community. So in that time, we've improved screening rates by more than double. It was around 40% and now it's over 80% of all kids. So the screening rates are improved. We can get in earlier and do things about it. But we've also improved the response time. So once we identify a problem, how long does it take to go and see a specialist? And we've changed that from about 70 days down to about a month. Outside of the hospital system, we're using video conferencing to connect up to kids in classrooms. And this is really important. We're working in remote communities. These are very low socioeconomic communities where families just can't afford the appointments to go and see a speech therapist, an OT or physio. By doing this, what we're actually doing, and I think this is doing 2 things. One is it's giving someone access to a service, but we're using our own students at the university who are in their final year under clinical supervision to provide these services. So our future generation of health professionals in the allied health area are learning how to do telemedicine. And these students are being snapped up around the country as soon as they finish because they already know how to do it and how to practice this remotely. And they do an amazing job. In 2012, I had an opportunity to actually build a telehealth centre. Now, normally I just get told where to go, and that's where your office is, and that's where you have to do your work, and just deal with it. but we had a clean slate. So we built a telehealth centre. This is focused on adult and geriatric services in a major hospital. Now, interestingly, and just going back to that slide, the telehealth centre could have consult rooms like an outpatient department. It had a main reception desk. It was inviting. People could come in there and people felt supported. Now, what people think is that the centre alone is not going to make telehealth work. This is what makes telehealth work. There's a lot of mechanical work that happens behind the scenes, and there's a lot of service development. You have to help people do business cases. You have to do education and training. You have to do evaluation. You have to support everybody. So you're changing all of these referral processes because the old ones don't work anymore. So which forms have to be changed? How do you bill? How does the money come back into the office? Who contacts who? All of that work is the change management behind the scenes that is really, really important. So in terms of activity, back in 2012 when we first opened it, the Health Minister came in, said congratulations, we've got a telehealth centre, it's one of the best in the country. In 2015, you can see what I'm doing here. I'm attacking all the different clinical services. Now we have staff in this centre that do a superb job at working with all the clinical groups. So I don't take credit for this, I'll work with them. But now, we could even fit all the services on in 2018. So lots of different areas, and we're still going. There's still a lot of people that we haven't got to yet. And people are now coming to us saying, we've heard about telehealth, how do we do it? So there's an increased awareness. So activity's going up over time. When we started, we're doing about 85 consultations. Now we're doing around 500. So every single month, and we've just exceeded 20,000 consultations just through this one loaner service. Another area I want to talk to you really quickly about is dementia care. We're working with some Indigenous communities in very remote locations in Queensland. Interestingly, dementia, the incidence of dementia is 3 to 5 times higher than non-Indigenous people. Sadly, we're doing screening for dementia at age 40, which is quite shocking really when we think about dementia in elderly people, but people are showing signs of dementia in the early 40s. So we're starting a screening program in very, very remote locations, just to show you some beautiful pictures. This is the kind of stuff you see when you go to rural and remote areas of Queensland and around Australia. But where those dots are on this nice painting of Queensland is where we're providing this project. And the project is about employing local health workers and training them up. So one of the keys is not to do it all yourself. You need to be able to transfer responsibility to people working in those communities. And telemedicine can support people and make it easier to provide additional specialist support to people who work in those areas. So we use video consultations. So once patients are identified as having a problem, they do screening, and then we give them an easy referral process where they can go through and refer to a geriatrician. It's difficult work because not only are we working in very remote locations, which are very difficult to get to. In fact, one of the places on the top corner there is Thursday Island, where it's showing that beautiful water. You can't swim there because it's full of sharks. It's full of crocodiles. So you can swim, but you won't come out. And I've seen them. I've stood on jetties and watched the tiger sharks eat the other reef sharks. I've seen other fish come up, and I've seen the crocodiles sitting on the ramps with their mouths open in the sun, waiting for you to walk down a little bit closer. And I just don't do that. But beautiful, beautiful areas. So on the left-hand side there is a family I met, and this beach is called Crocodile for good reason. And they said, take my photo, and here I am in water up to my knees. And you know what they said to me next? Any crocs around? Any crocs around? So here I am with clear water around me. They're jumping in and out of the water. They wanted me to check for crocodiles before they started splashing around. I felt really safe. Now, going from the beautiful surroundings of the Torres Strait and the islands that we're dealing with our Indigenous communities, I'm taking telemedicine into a different area, into the prison system. Just to give you one example of looking at hepatitis C treatment has radically changed, meaning that, you know, we've got a very high number of prisoners who have hepatitis C and they're not being treated. Historically, a lot of the medication regimes have required injections, serious side effects, and therefore it's been not touched. People don't do it. But there are new medications now with very limited side effects, which can be done under prescription. And we're using a process called ECHO, and this is around the world now. It's a tele-mentoring program. And the tele-ECHO program means that we can upskill people in the prison environment. We can assist with prescribing and support prisoners. So these prisoners now have access to this treatment. So we've been doing this as a hub and spoke model, teaching people how to not only prescribe, but support prisoners and give them the opportunity of having this medication. So under this study, we're using a framework which comes from Denmark. We're using a MAST framework, and this has a range of different dimensions, and we can handpick the ones that are relevant to us. And we're using this MAST framework for many of our telemedicine research studies. So looking at service activity, but also very importantly is taking it from the perspective of the staff involved. So what do people think, and what is it changing from their perspective? So we've conducted a range of different sessions. There's been just over 100 patients involved in the program. Many of those are completing the treatment or undergoing the treatment. We've lost a few because they've either moved to different prison facilities or they've just been let go, basically, and we just don't know where they are now. But this is really interesting, asking from the perspective of the clinicians, what's it doing? So in terms of access, impact on prisoners and staff knowledge, one person said, so we never were treating anyone, we didn't actually realise that we could. Another person said, well, it's a big stepping stone for the prisoners, it's a new lease of life. They can rid themselves of the Hep C and then just move on. And then the other one is, so I think it's a benefit because some people really understanding what we're doing and making it more efficient and safe, and the nurse practitioners really getting involved in that process, so it's including everybody. This jigsaw puzzle is here for a reason. Doing telemedicine requires lots of different pieces. Pulling it all together, again, takes a lot of effort. So importantly, and this is just a bit of a cheat list really, is making sure that your services focus on the clinical requirements. Now, I speak to many technical suppliers, people who write software, people who have the amazing gadgets, and they don't like me because I often say, well, what's it going to do? Whereas they've built this beautiful device without even thinking what the clinical problem is first. So from a clinician angle, I urge people to think about your clinical problem first before jumping into a technical solution. That's the best way to do it. Organisational support. I'm excited to be working in Denmark. I get to come here every year. I know that there's organisational support for telemedicine and interest in growing it. So you've got that big tick. You need clinical champions. You need funding models. So you've got to pay. It's not a freebie. You just don't do it because you think it's a great thing. In order for it to run as a sustainable health service, you need those funding models. You need training, you need change management, you need to be able to communicate and share records. You guys have one of the best electronic record systems in the world. You know, we don't have that in Australia. We're still moving to digital hospitals, but we're still a little bit disjointed. So you have that. And you need evidence. You know, for those who argue, you know, is it clinically effective, is it cost effective? We need to be able to address those, and we are. Times are changing. People are learning how to adapt to different environments. These poor birds are adapting to the fact they're not standing on wires anymore. We're going Wi-Fi. But this is just one example, is that we've got to catch up and we've got to keep working with what's available. So in the reverse, we're talking about barriers. I won't talk too much. Basically take your enablers and switch them around. In America, licensure is a major issue. It's not a big issue in Australia, and I don't think it's an issue here in Denmark. Having infrastructure, it's very hard to do telemedicine if you have no internet, if you have no equipment at all. So obviously you do need that as your baseline. Having access to services in a location that's suitable for clinicians. You don't want them to walk 2 kilometres down the back of the hospital, through the garden, through a shop, and then sit into a consult area. Giving people access to the technology in their own office is also very reasonable. Training is really, really important as well. We're building a training program. We've been running training programs for 17 years, and all of our students in our undergraduate elective courses and our medical courses are doing some of our subjects on telemedicine. But we're building a digital health curriculum which is a lot broader than just telehealth. So it's going to include mobile health, telemonitoring, some health informatics, some data analytics. So all of those aspects which all come together under this umbrella are very important. In terms of getting more information, just to almost wrap up, is that we run an international conference. Jane Clemenson has been to one of those as our keynote. Was that last year? And that was brilliant in Australia. We move them around the country, so we get people to talk about successes and failures in telehealth. So we actually get people to talk about the F word as well as the really good things that happen. Too many people get up on the stage and talk about all these amazing things, and they hide what doesn't work. And I think it's just as important to reveal what doesn't work so that we don't make the same mistakes. The Journal of Telemedicine and the American Journal are excellent journals to get information from. I'm the editor-in-chief of the Journal of Telemedicine Telecare, which is based in London. I think I review about 450 manuscripts per year. So I get to read a lot of information that comes from all over the world. So the reason I think I chose that job is because it forced me to learn about what other people are doing. So it's a real privilege to be doing that. Our website is there if you need more information, and I'm also part of the Australasian Telehealth Society. About my collaboration with Jane, and just to reiterate some points about what this collaboration is all about and what it does achieve, I feel quite confident about what we've done in 4 out of the 5 years. We've been working with a lot of PhD students. I've had the opportunity of seeing some of the defences and doing some of the PhD defences. I promise not to give people a hard time, but again, it's a really good opportunity for them to stand up and show the world that they're the experts on what they've done. And there are a couple of you in the room that have done that really, really well. So the examinations, joint publications, we've had a number of publications, and we've got some planned for next year. We visit each other internationally, obviously, and I invite you, if you're interested in coming over to Australia, to visit our centre and spend some time with us. We do presentations and we meet with each other on video. Just getting the time zones right, we tend to do that on a Monday when Jane's waking up and I'm about to go home, but it eventually works. Training opportunities and also looking at funding opportunities for each of us. So there's just some examples of the work that we do together. Now I just want to end on this point. Telehealth is a disruptive process, and I started with this point in my presentation. Telehealth forces us to rethink about the way that we provide services. And I think we should grasp that opportunity and use that as an advantage. How can we do better with what we've got, and how can telehealth make a difference? And it's a valuable method for everybody. It doesn't matter if you live thousands of kilometres away or only 1 kilometre away. Telehealth is here to benefit everyone. And I think we should use telehealth essentially to make sure we give access to everybody to the best quality services irrespective of where they happen to live. And on that note, I'll say thank you very much for the opportunity of being here, and I hope some of that information has been useful and hopefully inspired you to do some of your own telemedicine work in your own practice. Thank you.
Thank you, Anthony. Very important ending of the season of OOO Talks, because I think that about 10,000 employees ought to sit in this auditorium, so Anthony and I could look them into their eyes and see what's possible for the patients and the citizens. Of course, we are doing a lot of these things, but you show us that it's possible to take each specialty and perform some of their patients in this way. So this was very, very important for the hospital and for the region of Southern Denmark to think of this way of working. Now we have 15 minutes for questions. Any questions? Yes, Knud, 1 moment.
Thank you very much, Anthony. I think there's no doubt that we can do a lot of good things with telehealth and telemedicine, but can we harm patients as well? What is your opinion on that?
I think that's a really good question, and I think we often put the responsibility back on clinicians to decide if it's clinically appropriate. And I'm aware of studies that might use telemedicine and look at them over time to compare, and I think one study has you as the key author, looking at whether or not telemedicine for, say, patients with diabetes over the long term, whether it improves management of diabetes. I haven't personally seen any situations where it has harm, but we often have to have very clear guidelines about which patients are seen by telemedicine. One of the points is that it's never going to suit all patients, is very, very important. It's also very important that clinicians are comfortable that they can not only see patients by telemedicine, but they feel comfortable to bring patients back to them if they have to. So the worst case scenario is that you're seeing a patient and all of a sudden you decide, can't quite nail it, I don't know exactly what I'm doing, I need to see you in person. So we see many of those situations, and I don't think there's anything wrong with that. But I'm also seeing hospitals now totally change the idea of referring patients into the hospital. And just in the last month, one of our major hospitals in Queensland has made a radical step to ensure that all outpatient referrals, all of them, hundreds of thousands, are telehealth first before face-to-face. And that's a really valuable triaging service. So people have been triaged, they do their telemedicine consult, and then a decision is made. At best, they may be avoided a trip, or if they do have to go, then they get the right specialist at the right time. So I think it's just a much more efficient service. But clinicians worry that telemedicine is going to harm patients, but I think we have to see telemedicine as just one tool. You know, it's not one or the other, it's a combination. And I still go back to the point of saying that if we really look at the people who are coming into hospital every single day, and I think diabetes is a great example. We have a diabetes unit in Brisbane which is full every single day. A lot of these patients are not experiencing any major problems, but they've been told they've got to come back for their follow-up appointment. Now, what we're doing with those patients is we're collecting information remotely, so they use their smartphones to put their BSLs in and other information, and anything unusual will be picked up on a dashboard, alerted to a nurse educator, who will then contact the patient. That means our specialist is focusing all their attention on those patients who are really complex and unstable, and therefore the attention from the specialist is on that particular group, rather than seeing 30 or 40 people twice a day for no good reason. So it's about trying to get the balance right. I personally haven't been involved in any situations where I've seen any harm caused. There have been no lawsuits in Australia about telemedicine. People do get concerned. There have been issues raised in America, but that's America. And of course there will be, you know, people unhappy with the service. The other point I'd like to make about telemedicine is, if you and I had an option to see a doctor in person or not, or do it by telemedicine, then we'd probably choose seeing the person in person. But when you change the context and say, look, that's fine, you can see that doctor in person, but you've got to travel for 6 hours, take a day off work, organise a childminder and bring 3 hungry children in the car with you, they quickly change their mind. So it's about putting it into the context of what would normally happen if they couldn't do it by telemedicine, or if they did have to travel. So it's trying to understand all the different scenarios. Again, I go back to the point, telemedicine is not the only answer either. It's not going to solve every single problem.
Stephen Husby, Pediatrics. Brilliant talk. Thank you very much, Anthony. You showed us one robot, one slide with a robot. What will the future bring? Do you think that the robots will help us and perform simple procedures? This obviously mostly has been on communication, but will there be a procedure-oriented approach also?
Yep. That particular robot was it was functional in the sense of it able to do video conferencing, but it was dysfunctional in the sense that it didn't put any hands on the patient and do anything. I think your question about what the future holds in terms of interactive, you know, robots and devices, that will certainly be coming. There are already health kiosks that you can go into where you can have your blood pressure done. You can have a whole range of different diagnostic tests done without a human being in the room. We built many robots like that. We had 5 robots that we built. They lasted about 3.5, 4 years before the health department decided to use mobile video conference systems on trolleys, and now they've got hundreds of those systems all around the place. So that's where the robot kind of evolved into a mobile video conferencing unit, which is very, very common. Everybody uses them these days. But the other interesting thing is probably in the area of artificial intelligence. So there are systems now in place where you can do a dermatological consultation, where you can put information into a computer and it'll tell you your risk of melanoma, or it can tell you if a mole has a melanoma. The other one is looking at ear, nose and throat conditions. So there are companies now working with large data sets to be able to not only take a photo inside the ear, but all of a sudden tell you what the diagnosis is. So that's kind of shortcutting all of these other manual processes that require us to put our hands on the patients, send information to a specialist and get an opinion. So that's where I think the future is going. I think we're going to get smarter with the information we have. At the moment we rely on probably a few too many manual processes. There are robot systems doing surgery already. They've been around for about 15 years. There's the Da Vinci robot, which is a telesurgical system where you can do minor ops from a distance. Now the economics is interesting in that. One may ask, the cost of a Da Vinci robot versus the cost of sending the surgeon first class to the patient to do the procedure in person is questionable. The costs are eventually going to go down, but telesurgery is excellent for training, because if you're doing a unique procedure in a certain part of the world, you're not going to send all of the surgeons to that particular site. But if everybody can be present or participate during that process, then that's when telerobotics can be useful. So I don't think robots are going to take over.
No, they will help us. You have been talking a lot about the cultural changes among the physicians and the nurses and so on. What about the patients and the citizens? What are their opinion of this way of being handled?
Okay, so for about 10 years, I think we ignored them, is the honest truth. I think that was a mistake we made, is that we focused too much on the health service. Here, and what I've learned from the work happening with Jane, is that the patients are very, very important. I did a study about 7 years ago where I kind of took on that lesson, I learnt my lesson, and I started to go and showing communities what telehealth was, and we ran a campaign where we invited people to ask for telehealth. And what I realised is it was ammunition for the clinicians. So the more parents with sick kids and older adults with problems that walked into the GP's office and said, I want telehealth, they had no excuse. They had to find out what it was and they had to do something about it, otherwise they weren't providing the service needed. So I think the patient community is very, very important. Their awareness of telehealth is growing. I still think they need to learn more about what telehealth is all about, but I think the effort needs to be balanced. One thing you don't want to do is you don't want to create a big avalanche of patients coming into a hospital asking for telehealth if the hospital is not ready to deliver telehealth. So you have to balance both of those up.
Thank you. And now we have the last question or remark. Would you give a very difficult question to your colleague?
Yes.
Yeah.
And I haven't prepared him. Thank you, Anthony. It was excellent to hear. My question, I ask for some reflections because I don't think you have the answer, but it's due to the cultural changes, the change of management, the change of mindset, which is the success. If we want to do successes, we need those to focus on those areas, I think. But what we discover in Denmark is that we are very good at doing local projects and local implementations, but the barrier is when we go from local to regional to national. So how do you roll out the good results to other departments or other areas?
Every health service that I've worked in is quite different. Those that are all connected somehow, it's a little bit easier to grow a telehealth service, whereas those that are disconnected, you kind of find yourself working in a fragmented environment where you're very successful over here, and over here no one's doing anything, so that's when it gets really difficult. Probably the best way is to take a bit of a shortcut and go much higher up in the ministry and think about telemedicine as a policy effort to be able to improve efficiency in the health system. Once you start from a top-down approach, and I don't say that's the only way of doing it, I think you need both. There's no point in having ministers and people at executive level saying do telemedicine without drivers coming up from the clinician angle. So I think you need to be able to do both, but it's hard to do one without the other. So I think joint effort. In Australia, we've had pretty major policy changes where all of a sudden we've had funding made available for telehealth. So it doesn't matter if the patient comes in to see you in person or if you see them virtually on a video conference system, you now get reimbursed or funded to provide that as a fee-for-service arrangement. There are some limitations to that at the moment, which we're talking to the government about. And some of those limitations mean that currently our funding is just for doctors and it's not for nurses and allied health staff, and I think that's a big mistake. Telehealth is also been funded for the live interactions, but not the store and forward interactions, and again that's a big mistake. So aside from the government, then we've got health departments underneath that who can choose to set up their own telehealth strategies, and that's another very good idea. So in Australia, we're working with the Tasmanian Health Department, and we had a 2-year contract, and we wrote them a telehealth strategy, and they've recently just endorsed that strategy and all our recommendations on a governance structure, and also some incentives. And I say incentives very carefully, and it's not just financial incentives, but it's incentives to start changing the way that we employ people. So position descriptions, all of you should make sure that the PDs include telehealth as an expectation, because next time someone comes to you and say I'm not doing it, hand them back their PD and let them know that their position description explains that they will do telehealth consultations as well. The funding is important, giving people support and training, so not expecting them just to do more because it's a good idea, but acknowledging that it's an important part of their work, so allowing time and allowing the system to support them. So it's hard to be a clinical champion if you don't have support of the system. So there's probably a number of different areas. The fragmentation is not unusual, so if you feel yourself in a situation where you've got a lot of activity here and nothing over there, the key message there is it takes time. Eventually one will think that they're missing out and someone's doing something really, really good, and eventually they'll catch up. So when I worked with a group of surgeons, that was my example where they just didn't want to touch it, they didn't want to go anywhere near it, and then eventually I talked one of the surgeons into doing the work. After a month he was seeing only a few patients, he didn't want to do any more than that. And then his colleague was talking to him and she said, oh look, I want to do that as well. So, and then the third burns consultant did it, and then the fourth one did it, and then soon they were comparing how many patients they'd seen each month, and they were becoming very competitive people. After a while it was a competition, and they were seeing how many they could, but it took time and it was very frustrating. The burn surgeon who started that now goes to conferences saying back in 2004, I had this great idea to do telemedicine. So again, it takes time. Don't be put off by the fact that it's happening here and not happening there. It's very, very important to get executive support. It is a culture change. We're changing the way that we work. So we're all trained to be doctors or nurses or allied health staff. Times are changing. Scope of practice is changing. You need the professional organisations on board as well. So there's lots of different arms. But just to reiterate, the patients are very, very important. And I'm not saying that, I guess, Jane, just for your benefit, because I know that's kind of a big area of your work. But looking at it from a consumer perspective, we do need to be able to support them.
Sorry to stop you, because we could listen to you for hours. I think we have to put our hands together again and say thank you Thank you so much to Anthony. This was very, very important ending of the season of OUH Talks. The first speaker after our Happy New Year, I hope, is Professor Alexander Krau from our International Elite Research Center, FLASH, talking about liver diseases, some results and at least a lot of problems, I think. So welcome next year, and thank you again to Anthony.
Yeah.